Hello, and let me first say what a great pleasure it is to be a part of this session, and of course, what a pleasure and privilege it is to be with so many good colleagues and friends of many years in Egypt. So today I'm going to talk about the similarities and differences between the main guidelines in the US and Europe. I have no conflicts of interest, and I just show here the main publications or some of the main publications from these two guidelines. So let's start first by talking a little bit about clinical practice guidelines. And one could say they're especially helpful when the condition is of common and expensive. And certainly that applies to blood pressure, where the practice patterns vary, and we know they vary tremendously with management of blood pressure, and where we have a sufficient quality and quantity of the body of evidence, in this case around risk and treatment. And we probably have the best body of evidence anywhere in medicine in blood pressure. So this is an area where it's very well suited to a clinical practice guideline. Now, there's a long history of practice guidelines. They started initially in the US. The sort of granddaddy is the Joint National Committee, started in 1977, and there were many iterations of that. It was supported by the National Institutes of Health. Shortly afterwards, there was a WHO guideline and then a series of WHO ISH guidelines. The Egyptian Society, Hypertension Society had guidelines early, and the first one, of course, in 1998 and several subsequently. The European Society of Hypertension had guidelines in conjunction with the European Society of Cardiology starting in 2003 up to 2013, and then it flipped to 2000 to European Society of Cardiology and European Society of Hypertension in 2018, but basically the same group. Joint National Committee went out of business in the 2013 when the National Institutes of Health decided they weren't going to do guidelines anymore, and they ceded that responsibility to the American College of Cardiology and American Heart Association jointly. They formed a writing committee in 2014 and then published a guideline in 2017. So one could say that guidelines are developed by a variety of groups, professional societies, government agencies, international bodies. Often there are multiple guidelines in large countries and regions like the US, China, and Europe. In the early guidelines, there was a substantial concern around conflict of interest. There were very close ties to industry. And there were a lot of concerns about methodology. There were so many concerns, in fact, that in the late 1980s, the US Congress asked the Institute of Medicine to look into this and to develop best practice guidelines. More recently, the guidelines have shown a lot more rigor in development. In the US, the Institute of Medicine produced several reports around best practices for developing a guideline, and the most recent one is Clinical Practice Guidelines We Can Trust, that was published in 2011. And that report stressed 8 key areas for any major guideline: transparency, avoiding, preferably, or if not, at least managing conflicts of interest, who should be on the writing team, when a systematic review and meta-analysis should be undertaken, what should provide the foundation for the evidence to support the guideline, how should the findings be articulated, what sort of external review should a guideline go through, and how often should a guideline be updated. And that really has informed the major guidelines in the US subsequently. So the primary responsibility for a clinical practice guideline writing committee is to provide the best evidence-based recommendations possible for practicing clinicians. This has been the core consideration for both the US ACC/AHA and European ESC/ESH clinical practice guidelines. An important secondary responsibility is to try to provide guidelines that are feasible for implementation. And again, both of the guidelines have considered this seriously. Comprehensive guidelines are, by their nature, long, and yet they're tend to be formatted so that they're easy to follow, the same format throughout each chapter. And you can go to any chapter and really get to the questions pretty quickly. So in addition to that, these two guidelines in particular have had a whole series of executive summaries, short summaries, short articles, slide sets, videos, website information, algorithms. So a lot of shortened versions are widely available. Now, if we compare and contrast the two guidelines, first methodology, a good deal of similarity. Multidisciplinary teams, there tended to be more non-physicians included in the US guideline, but both were multidisciplinary with individuals in primary care and specialty care. The European guideline tended to have hypertension experts throughout. The process in the US required that there be no relationship with industry, and that's pretty important to ACC, AHA. The European guideline allowed relationships with industry, but it was very transparent. It was a very formal process in both settings. The ACC and AHA, for all of their guidelines, have a very well laid out and formal process. Likewise, the European Society of Cardiology, European Society of Hypertension. Extensive literature review. There are systematic reviews and meta-analysis required for the key questions by ACC, AHA. And there is a requirement for very detailed evidence tables. There are 448 produced to support the ACC-AHA guideline. Extensive peer review for both of these guidelines and approval by the sponsors. In the case of the US guideline, in addition to ACC and AHA, there were 9 collaborating professional societies. And then all of the recommendations are identified with what's called a class of recommendation, or COR. It's really the strength or the importance of the recommendation, and a level of evidence, or LOE. What is the confidence one has in the level of evidence supporting this recommendation? So that's identical in the two guidelines. Now, both guidelines started with the premise that you've got to measure blood pressure properly. So there's a very strong emphasis on measurement accuracy, on getting repeated readings. The US guideline used what had been in JNC for many years, an average of 2 or more readings on 2 or more occasions. Slightly different in the European guidelines, but certainly wanted to get an average. So we're trying to get at the best estimate of usual blood pressure. Both of the guidelines recommended out-of-office blood pressure readings. In the case of the US guideline, to confirm office hypertension, and was a recognition that ambulatory blood pressure monitoring would be better, but not very practical in the US, and home blood pressure monitoring was the one that mostly was going to be used. In the case of the European guidelines, hypertension could be confirmed either by repeated measurements in the office or by repeated measurements out of office. Both guidelines recommended out-of-office blood pressure measurements to confirm or refute the presence of masked hypertension and white coat hypertension. So again, a lot of similarities around this area. The biggest difference really was in the definition or categorization of blood pressure. This is, of course, artificial and arbitrary because in terms of risk, what the body recognizes is level of blood pressure, average level of blood pressure, but it's useful to have categories for clinical practice. So there was agreement from 140 systolic and above and 90 diastolic and above. Both guidelines call this hypertension. In the case of the the US guideline, it was kept simple as one stage. In the case of the European guideline, this was graded into levels of severity of hypertension. For 130 over 139, the US guideline, based on risk and treatment experience, decided that it should be called stage 1 hypertension. They also applied that to diastolic 80 to 89. In the case of the European guideline, 80 to 89 diastolic and 130 to 139 systolic was called high normal blood pressure. So that's probably the biggest difference, and that does mean the prevalence of hypertension using the US guideline is considerably higher than the European guideline. Now, when it comes to risk, both guidelines recommended that risk be assessed in addition to blood pressure for treatment decisions. So in the US guideline, atherosclerotic risk was what was recommended as a central facet for treatment decisions, especially as one got down to the starting levels of hypertension, stage 1 hypertension. And high atherosclerotic risk could be identified where an individual had a prior history of cardiovascular disease, or where the use of a calculator, and in the case of the US, it's the ACC-AHA pool cohort equations calculator, where the 10-year risk of an event was 10 or more percent. The guidelines said that we would recognize that many clinicians are not going to do that calculation, and so they said it is reasonable to assume high risk in adults with hypertension who also have diabetes, chronic kidney disease, or older, 65 years of age or older. The European guideline, I should say the ACC-AHA calculator is validated in the US for whites and blacks, so that's why that calculator was chosen. The European guideline uses the SCORE system, and that is also validated in Europe. And it has 5 gradations from low to very high risk. And you can see some of the factors that are driving that decision. That guideline is validated in Europe. There are 2 core versions, a core version for high-risk countries tending to be the Eastern European countries, and for lower risk countries, the ones more to the west. There are also 16 national versions of that calculator, and it's like the US, available on a variety of apps and websites. Now, what about treatment? Well, there's a lot of similarities when you get to treatment. The classification differs, but the treatment is really quite similar. The US guideline goes across the panoply of blood pressure from normal all the way through to stage 2 hypertension. And it recommends lifestyle management across the board. And then when you get to stage 1 hypertension, what the guideline says is really important to understand underlying risk. If underlying risk is high, then it is appropriate to add in antihypertensive medication. And if it's not high, it's not appropriate to do that. It should continue with lifestyle management. In the US, about 30% of adults with stage 1 hypertension have a high atherosclerotic risk. They recommended lifestyle and drugs for all patients with stage 2 hypertension. The European guideline starts with high normal blood pressure and basically says across the board from high normal all the way through the highest category of hypertension, lifestyle advice is appropriate. And then for the high normal, which would be the closest thing to stage 1 for the US guideline, it recommends considering adding medications in very high risk settings, particularly individuals with coronary artery disease. When you get to 140 and above, both guidelines are very similar. They recommend adding antihypertensive medication in addition to lifestyle. So really fairly similar. What about the target for blood pressure management? The US guideline recommends a target of less than 130 over 80 for all adults, with the exception that systolic is the only thing that is recommended to follow for older individuals who are non-institutionalized ambulatory and community living. That is, we defined older adults as 65 and above. That's, of course, arbitrary. Now, for older adults with a high burden of comorbidity and limited life expectancy, the guideline says it's reasonable to base treatment intensity and drug choice on clinical judgment, patient preference, and a team-based approach to assessing the risk and benefit of management. The European guideline does it in two stages. Says first, target systolic and diastolic less than 140/90, and as long as the patient is tolerating that, press on to get to lower blood pressures. And you can see the pressures that are recommended for most people: 130 or lower systolic if tolerated, but does recommend not to go less than 120, something the US guideline did not include. A slightly higher blood pressure target was recommended for older adults, and the diastolic generally recommended was 70 to 79. So some differences, but a lot of similarities. What about the components of therapy? Well, both guidelines underscored the fundamental importance of non-drug therapy, or mostly it's going to be lifestyle management, because that is dealing with the underlying cause of most high blood pressure. And both guidelines recommended healthy diet, weight loss, sodium reduction, physical activity, and alcohol cessation or moderation. In addition to that, the US guideline recommended potassium supplementation, preferably by diet. The European guideline did not include that recommendation. Both guidelines recommended tobacco or smoking cessation, not for blood pressure management, but for general prevention of cardiovascular disease. When it comes to antihypertensive drug therapy, the two guidelines have the same general recommendations. That first, one should treat comorbidities, and oftentimes that will require drugs at a lower blood pressure, and that will decide or determine the first step agent for lowering pressure. If there are no compelling indications, both guidelines recommended the use of agents from four classes: diuretics, calcium channel blockers, angiotensin converting enzyme inhibitors, and angiotensin receptor blockers. The two guidelines recommended combinations for most people. In the US, we recognize that combination therapy, particularly as a single pill, was desirable, but often was more expensive than using the two pills separately. And oftentimes the dosing and choice of agents were not great. But we recommended combination therapy, especially for those with a high starting level of blood pressure, and in all African Americans who have a disproportionate complications from any level of blood pressure. In the European guideline, there was strong emphasis on the use of initial combination therapy, particularly as single pill combinations. Now, both guidelines addressed particular management for a variety of comorbidities, patients with comorbidities and hypertension. They also addressed special groups, and there were a variety of other considerations that they both covered. So very similar in that respect, and much of the advice is pretty similar too. Both guidelines stressed approaches to improving adherence and control rates. So adherence, structured team-based care, technology, quality of care, incentives, all of the issues that were stressed in the American guideline. European guidelines, strong emphasis on single pill combinations and algorithms for medication management. They both addressed additional concomitant cardiovascular disease management. They provided follow-up guidance both for initial control and for routine management of high blood pressure once it's treated. The US guideline provided a fairly detailed plan of care for patients. The European guideline did something very similar. They had a different title to it, what to do and when to do it. They both provided summary tables, and they both identified gaps that need to be addressed by future research. Now, it's natural when you look at guidelines and compare them to look for differences, and that's understandable. But usually that's the focus of papers and presentations about comparisons of guidelines. And the focus usually is not looking to see where the commonalities are. So this is an example of a paper that, they often try to hype the differences. So the blood pressure landscape, schism among guidelines, confusion among physicians, anxiety about patients. I don't like these articles very much because they really tend to cast doubt and confuse people. And I think I much prefer when we look for commonalities. What are our common areas? And likewise, my colleagues in the European guideline think the same way. Brian Williams, who chaired the European guideline, and I chaired the US guideline, wrote together a paper for JAMA stressing the similarities, and we said more similar than different. Several of us from the two guidelines were commissioned by ACC, AHA, and the European Society of Cardiology to write a more detailed review of the guidelines and how we can work in the future to continue reconciling as best as we can, or as much as we can, guidelines on both sides of the Atlantic. So when we look at the blood pressure clinical practice guidelines, differences are natural and they should be expected because these guidelines are developed for different populations. There are different stages of hypertension awareness, treatment, and control. If you don't have much control even of the higher pressures, obviously you have to focus there first. When you're doing better in that context, then you can start to move to the lower pressures, which can contribute to a lot of the blood pressure related events. They have different systems of care. They have different health needs, and they have very different socioeconomic status, and the culture of how medicine is practiced is very different. So it's natural that there would be differences. Some recommendations are quite transportable. So in every guideline, what you'll find is the attention to blood pressure measurement issues should be virtually identical. And on the other hand, some things are not transportable at all. So cardiovascular disease risk estimation, we know that risk estimators that work well in one population do not work well in another. So it's much better to be using a risk estimator that has been validated in the population of interest, if that's possible. Now, sometimes that's not possible. Writing committees may interpret the same data differently, usually slightly differently, and certainly they may employ different methods for decision making. So it would be silly to think that all guidelines should be the same, and certainly to think that guidelines around the world should be the same. So in summary, clinical practice guidelines are particularly useful in high blood pressure. There are many clinical practice guidelines. There's a smaller number of guidelines that have been independently developed and are comprehensive. Two of those are the 2017 ACC-HA guideline and the 2018 ESC-ESH report. As I said, it's natural to have guideline differences and similarities, but we tend to highlight those differences. That's understandable, but it is confusing, and it leads potentially to the belief that even the experts can't agree. And it can, easily result in therapeutic inertia. I think the ACC-HA and ESC-ESH guidelines have a lot more similarities than differences. We've both moved in the same direction for more intensive management, for looking at functionality in older people rather than purely looking at chronological age. It's important, I think, to highlight the core commonalities rather than the differences of these guidelines. we have a common problem, and it's insufficient treatment and insufficient control all around the world. It's an enormous problem, and we all need to band together to try to address that problem. So with that, I'm going to say shukran. Thank you very much. Wonderful to be a part of this World Hypertension League Symposium at the Egyptian Hypertension Society meetings. I look forward to being with you in person, hopefully, perhaps next year. Thank you.
The informative talk. I think the difference between guidelines that when and how to treat patients according to risk factors, and what is the modality of treatment, either lifestyle modification only or accompanied with medical treatment, and when to begin medical treatment, and what is the approach and the target for continue medical treatment. I think the American Heart Association guidelines more tight control for blood pressure than European. What's your opinion about this?
Yes, first off, wonderful to be with you. I would say my opinion is the guidelines are pretty similar. We're both recommending more intensive treatment. We're both recommending the same approaches to treatment, both lifestyle and how to use drugs. We are certainly recommending a little more intensive treatment in the US. And of course, we're all waiting for additional intensive treatment trials to provide the results. There are several big trials ongoing at the moment. I'm involved with 2 in Brazil and with 1 very large one in China. So I think we will get additional trials on intensive blood pressure reduction down to 120 or below. So I'm going to guess in future guidelines, if those trials document benefit, the type of benefit we've seen in SPRINT, that our next set of guidelines may actually recommend a lower blood pressure target. I personally am in the senior category, and I have high blood pressure, and I keep my systolic under 120 with ease. I take lisinopril and a combination of a calcium channel blocker, a diuretic, methylphenidone, and an ACE. And I follow reasonable lifestyle approaches, and it's very easy for me to keep my pressure low. Not everyone will be as easy, but I think we're using the same therapies and gradually moving to more intensity of treatment if that can be achieved.
Thank you, Paul, for this very informative talk. But unfortunately, in many developing countries, we cannot afford this very aggressive approach in lowering the blood pressure. The majority of our patients pay for the drugs out of their own pockets. We do not have an insurance system that covers the majority of the population. And this is a lifelong treatment for a disease without symptoms. So we have to make a compromise between what is possible and what is ideal. And furthermore, the diagnosis based on numbers is not easy because we have more than one method for checking the blood pressure. Are we going to for the office measurements? Are we going for the ambulatory measurements? Are we going for the home readings? Are we going for automated office measurements? Because these will differ. And therefore, we have to find a way or a compromise. In many developing countries, we rely mostly on the office measurements, and we have to improve on the diagnostic approach, and we have to stress again the lifestyle and the advice for the public. But still, these aggressive levels of blood pressure and the levels of 120 are, I hate to say it is unachievable, but are difficult to achieve in many developing countries. Yeah. Thank you.
Thank you, Mohsen. I completely agree with you. So I would always stress that guidelines are not necessarily transportable. They are written for a particular population, and that population has all, the differences of where they are in the journey of managing high blood pressure, the socioeconomic system, the healthcare system, culture, and so on. So I agree that for Egypt, you need your own guidelines, which you have, and they have to be tailored to that population. There's no question that in many countries, we're not doing anywhere well as we should be, even in the US. We have a guideline that will be coming out soon, quite soon. It's a WHO-sponsored guideline trying to put out a global estimate of what to do. And I am glad now, as I know you are, that for the first time in my professional career, we have a serious attention by WHO in non-communicable diseases. And we have several other groups resolved to save lives, with 225 million from Blumberg Foundation, Gates Foundation, Zuckerberg. I'm the president-elect of the World Hypertension League, and all of those groups are very, very active now in trying to work in less economically developed countries to implement approaches where we can have a sustainable approach with management, relatively inexpensive combination therapies. We've gotten dual and triple therapies on the WHO formulary, which of course is a way to get it into other Ministry of Health formularies. It took quite a while to do that. So we're making progress, and I'll give you an example. In the Americas, Pan American Health Organization, which is the official body of WHO. It's an independent agency, but it's the official body. We're now active in 16 countries. We've had enormous changes in very short order, in several years, from the teens, the 5 or 6% control rates, up to 50% control rates. So I think it is feasible to do it, but it has to be something where there's a strong buy-in from the government, and there has to be a systematized approach. The good news, I think we'd probably all agree, is what works well as an evidence-based approach to success in the US is the same sort of general approach that works well in even the country with the least developed economy. So I am hopeful for the future. And I congratulate the European Society of the European Hypertension Society, because you were out there very early on with your own guidelines.
Thank you very much, Dr. Whelton. Thank you.
Pleasure.